Hello everyone. This is Dr.Sohil Vadiya here. I'm an associate professor in a private medical clinic in Ahmedabad, Dr. M. Kesha Medical College. We will be talking about the facial nerve and its diseases today. So, what we basically know about the facial nerve is that it's a seventh cranial nerve, and you can see my email ID on the screen. If you have any queries at the end of the session, you can leave an email to me or try to reply you back. So the learning objectives for this session is that at the end of this session, we want all the students to at least be able to mention the different parts of the nerve and different branches of the nerve, and also describe a proper plan of management for idiopathic or traumatic weakness of the facial nerve. The idiopathic facial nerve palsy that we commonly know as Bell's palsy. Fine. So what we know about the cranial nerve is that it has a nucleus, it has a supranuclear part, and it has an infranuclear part. This is common for all of the cranial nerves. The nucleus is situated in midbrain, pons, or medulla. The supranuclear part connects the nucleus with either the cerebral cortex or a thalamus or any other higher center, mostly of the opposite side. Or it may connect to all of them, like in facial nerve of cerebral cortex and other side of thalamus as well. And there is an infranuclear part. That means the part after the nucleus, when the nerve leaves the brainstem and then. So for the facial nerve, there are three main parts of the nerve. There is an intracranial course, there is an intratemporal course, and an extratemporal course. So intracranial part means before the nerve enters the internal auditory canal of the temporal bone. That is the intracranial part. Intratemporal part means the nerve, the part of the auditory canal, then inside the middle ear, and also the extratemporal part means when the nerve leaves the stylomastoid foramen, comes out of the skull, and then joins into the parotid gland. That is the extratemporal part. So we'll talk about the intracranial part first. So let us be very clear that the intracranial part means the part of the nerve which is in the nucleus. The nucleus is in pons. Supranuclear part means the connections of the nucleus with the opposite side of cerebral hemisphere in the cerebral cortex, which is the supranuclear part. The nucleus itself, which is seen as a red nucleus here in this picture. The infranuclear part, when the nerve goes and leaves the nucleus and then leaves the pons. So this much is intracranial part, which has supranuclear part, nucleus, and infranuclear part. That is intracranial part of the facial nerve. It has all the three components. In the intratemporal part and extratemporal part, it is only the infranuclear part of the nerve which goes there. Fine, we understand this much. Now, the nucleus in the pons is located near the nucleus of abducent nerve and also near the superior salivary nucleus. The infranuclear nerve that leaves the nucleus takes a turn around the abducent nerve nucleus and superior salivary nucleus. Then this nerve becomes the infranuclear part of the nerve. Okay, fine. Where does it go then? That we will see. The supranuclear part has connections with precentral gyrus of the opposite side, and also that the lower face is supplied by the fibers from only one side, that is only the opposite side of the cerebral cortex, whereas the upper part has connections with both the sides of supranuclear compartments. So whenever there is a supranuclear paralysis, suppose that on the left side there is someone suffers from a stroke and there is a supranuclear paralysis on the left side of the cerebral hemisphere, the person will have a right side facial nerve palsy because the left side of the cerebral cortex supplies the right side of the nerve. the right side facial weakness will be there, but that weakness will be seen only in the lower part of the face, and the upper part of the face will not be having any weakness because the same side also gives some fibers to the nucleus of the facial nerve, and the right side is not damaged in this case. So in supranuclear palsy, only the lower part of the face is paralyzed, not the upper part. The nucleus also receives connections from thalamus, so that we have emotional control of the facial muscles, involuntary control of facial muscles. So after it leaves the pons, here is the pons area. When it leaves the pons, the nerve goes into this area, which is known as cerebello-pontine angle. So cerebello-pontine angle, we can understand from this diagram that here are the two cerebellar hemispheres, and here is the pons. So after leaving the pons, the pontine angle. Remember, CP angle or cerebello-pontine angle is a very good landmark, very important landmark of the intracranial benign tumors arise in this area. The most common amongst them is a meningioma, and the second most common is an acoustic neuroma. So after the cerebello-pontine angle, as you can see in this picture, the nerve goes more laterally. Where it would go? It goes into the temporal bone. So the first part of the temporal bone that comes into contact with the facial nerve is called the internal acoustic canal, the IAC area, the internal acoustic canal area, where the nerve travels. It is almost an 8 millimeter long part where the nerve runs into the canal, and it runs along with the 8th nerve. That means the cochleovestibular nerve. At the end of the canal, at the lateralmost part of the canal, the facial nerve then becomes the labyrinthine segment of the nerve. Labyrinthine segment of the nerve is the narrowest portion of the nerve, is the smallest portion of the nerve. Why narrowest? Because this is the area where the nerve has the minimum thickness. So if there is slightest of edema, the nerve becomes weak. The facial muscles get paralyzed. This area is the most vulnerable, and it is also smallest, only 4 millimeter long. So labyrinthine segment, then the nerve becomes the horizontal part, and then it becomes the vertical part. So in this picture, we can see that here is the medial end of the internal acoustic canal. From here, it travels. Here, it becomes the lateral end of the canal, where the cochleovestibular nerve has also divided into cochlear part and vestibular part, and the vestibular part in turn has divided into superior and inferior vestibular nerves. This is the facial nerve. So at the lateral end of the internal acoustic canal, the facial nerve becomes a labyrinthine nerve. The labyrinthine nerve then goes ahead. As we can see, it goes above the labyrinth. This is the labyrinth. The entire vestibulocochlear portion is the labyrinth. That's why the nerve is called a labyrinthine portion of the nerve. Fine. So after the labyrinthine portion of the nerve, here we see that this is the labyrinthine portion of the nerve. Labyrinthine portion of the nerve then becomes a horizontal part of the nerve, or it is called the tympanic part of the nerve. The junction of labyrinthine portion and tympanic portion is called the geniculate ganglion, from which the first branch of the nerve arises, which is known as the greater superficial petrosal nerve. Fine. So greater superficial petrosal nerve is the first branch of the facial nerve that arises at geniculate ganglion at the junction of labyrinthine and tympanic portions of the nerve. Then the nerve continues horizontally. It goes above the stapes area. This is the stapes bone. Here is the stapedius muscle. It rides above the stapes area, and then at this portion, it becomes the vertical portion of the nerve. At the junction of vertical portion and horizontal portion, the second branch of the nerve is given, which is known as nerve to stapedius. This nerve supplies the stapedius muscle. The stapedius muscle is actually a protective muscle which takes the stapes out of the oval window when there are loud sounds. That is the function of the muscle. And the third branch of the nerve arises from the vertical portion, which is known as the chorda tympani nerve, which goes to the submandibular gland and supplies parasympathetic secretomotor fibers to submandibular and sublingual salivary glands. It also takes the taste fibers from anterior two-thirds of the tongue. At the level of stylomastoid foramen, the nerve passes through the stylomastoid foramen and becomes the extratemporal part of the nerve. Fine, so there is a cranial part, intracranial part, there is a temporal part, intratemporal part, and now there is this extratemporal part. All the three branches we mentioned, they arise from the intratemporal part. The function of greater superficial petrosal nerve is to provide secretomotor fibers to lacrimal glands and also to provide secretomotor fibers to mucosal glands in the nose and some of the glands in the mouth as well. So this slide basically is to explain you the origin of all the three branches. So it is intratemporal part. This is the labyrinthine portion. The junction of labyrinthine and tympanic portion is the first branch, greater superficial petrosal nerve or greater petrosal nerve. The junction of the tympanic and mastoid portions is called the second genu. This is the first genu, this is the second genu. At the level of second genu arises the second branch, which is known as the nervus stapedius, and from the vertical portion arises the third branch, which is known as cauda tympani branch. Fine. So when the nerve comes out of the stylomastoid foramen, it gives off two muscular branches, one to the stylohyoid muscle and the other one to the posterior digastric. And then the nerve enters the parotid gland, and inside the gland the nerve divides into its terminal branches. Generally there are 5 muscular terminal branches. So extratemporal part, let us discuss that. As we know that it comes out through the stylomastoid foramen, then it goes to the stylohyoid muscle and digastric branch. 2 branches are given then, and then the intraparotid part, where there is an upper division and lower division. In turn, these 2 divisions divide into ultimately 5 branches that supply the muscles of facial expressions. They are motor branches. So generally from the upper division, 2 branches arise. The upper one is known as the temporal branch, the lower one is called the zygomatic branch, and from the lower division, the 3 branches arise called upper buccal, lower buccal, and cervical branches. This diagram is to show the composition of the facial nerve. So a cranial nerve, or any nerve in our body for that matter, has a composition or the function or the structure in the form of axons. Then there is a myelin sheath that surrounds the axons. Then there is endoneurium, and in the endoneurium there are nerve fiber bundles there. Endoneurium then again is surrounded by a perineurium, fibrous perineurium, and then the entire nerve ultimately is surrounded by apineurium. So these are the layers of any nerve, the composition, the structure of any nerve. Why we are learning this? Because if there is a nerve injury, the injury is classified according to these layers of the nerve. So the Sunderland classification says there are 5 different levels of nerve injury, and ultimately they are known as neuropraxia or axonotmesis and neuronotmesis. So the 5th grade, where there is a complete transection of nerve, no continuity. The 4th grade, where there is only apineurium, is are cut. Whereas in level 3, we can see that partially intact, and in level 1, there is hardly any cutting of the nerve, no cutting of any fibers. There is only an edema. The level 2 is in between. So these are the 5 grades of nerve injury, and the management of the facial nerve injury depends upon the level of injury. There are many electrical tests through which we can come to know about the grade of injury. We can come to know about the number of fibers which have been damaged in the facial nerve. Mostly electroneuronography is done generally after 4 days of injury. 4 to 15 days is the time where electroneuronography is the most useful. Electroneuronography, basically, electroneuronography tells us how much is the damage, how many fibers of the facial nerve are actually lost. It tells us the percentage of the nerve fibers which are not. And after 21 days of injury, electromyography is done, which tells us whether the nerve is having any polyphasic potentials or fibrillar potentials. Polyphasic potentials tell us that the nerve is recovering. Fibrillar potentials, they are also telling us the nerve is working. And if there are no potentials on electromyography, that means the motor end plate is completely damaged, and then there is no way that the nerve can regenerate. There are many topognostic tests, or they are known as topodiagnostic tests, because there are three branches of the nerve. So if there is an injury above the first branch, then all the functions of the facial nerve are lost. If there is injury in between the first and second branch, that means in the horizontal portion of the nerve, that means before the nerve to stapedius is given, then only the function of first branch or greater superficial petrosal nerve, that function is lost. Which is that function? The lacrimation. So if we test clinically by putting a filter paper in the fornix of the eye and see the humidity on the paper, we can come to know that the lacrimal flow is less or more. That is called as Schirmer's eye test. If the lacrimation is reduced, that means the first branch of the facial nerve is not functioning very well. That means the injury of the nerve is above the level of the first genicle or the genicular ganglion. If lacrimation is normal, but the stapedius muscle is not functioning well, that means the injury is between the first and second branches. And if the stapedius muscle is also functioning well, but the taste sensation or salivary flow from the submandibular gland is reduced, that means the injury is between the second and. So that's why they are called topodiagnostic tests, because they tell us the level at which there is an injury of the facial nerve. So once we know that, okay, this is the level where there is an injury, this is where the nerve has been damaged, we can proceed for the management. Okay, this diagram is only to show you the labyrinthine portion of the nerve. Okay, so now we'll see some of the clinical problems with the facial nerve. So if Bell's palsy is known as when there is an idiopathic facial nerve dysfunction. Generally, it is very rapid onset and it is complete type of paralysis. So many people believe, so much research has been done to know if it is caused by herpes simplex virus or not. But still, there is no clear-cut agreement that it is caused by herpes simplex virus. But we can give antiviral drugs for this. Okay, so far as the research completes and everybody agrees, we'll call it an idiopathic Bell's palsy. Okay. So it's a peripheral neuronopathy, and generally it involves one facial nerve, and there is a complete paralysis generally in these cases. Good part is that the Bell's palsy recovers in more than 90% of the people, and the facial nerve function resumes completely. There is a complete recovery in many of the patients, most of the patients. How it presents? Whenever there is a facial nerve paralysis by Bell's, it generally involves a labyrinthine portion. That means all the function of the facial nerve would be lost. It's an infranuclear type of paralysis. There will be incomplete closure of the eye because orbicularis oculi muscle will be paralyzed. There will be deviation of the mouth to normal side because the normal side of working, but the paralyzed side, it is not working. So that's why the mouth deviates towards the normal side. Bell's phenomenon is a phenomenon when there is an uprolling of eyeball when the patient forcefully tries to close the eye. Why it happens? Because the patient, the eyelid is not closing. The upper eyelid is remaining up, not coming down. So patient would believe that, okay, subconsciously, if I move my eyeball up, it would be covered by the eyelid. That is known as a Bell's phenomenon clinically. There will be drooling of saliva while eating, and there will be air leak when trying to blow. So this would be the presentation. Mostly there is near normal recovery in more than 90% of the cases. Observation, medical treatment is given in the form of steroids and antiviral agents. Not everybody is giving because we are still waiting for the agreement. Surgery is done in very selective cases when there is 100% facial nerve palsy, it's not improving after steroids, and there are fixed criteria. Or if there is facial rehabilitation and if there is dynamic versus static reanimation, which is required to be done. So that's an algorithm here. If it is acute paralysis, paralysis means incomplete paralysis. Acute paralysis means there is a complete 100% non-functioning of the facial nerve that we assess clinically. So if there is an acute paralysis, complete paralysis, on day 0 to 3 we give prednisolone, and then after 3 days when we will be able to do electroneuronography and see if there is more than 90% fibers of the facial nerve are not working, there's a degeneration involving more than 90% of the fibers. That requires, these are the cases where a decompression of the facial nerve should be carried out. So many methods are there. Middle cranial fossa decompression is one of them, which is most popular. There could be other methods also surgically. If the degeneration is less than 90%, then we don't need to explore and operate. More than 14 days, generally, exploration would not provide us with much benefits. If there's acute paralysis, then this is the follow-up protocol. Now, the facial nerve can be damaged by fractures. Which fractures? When there is a head injury, there could be fracture of the. If there is a fracture of the temporal bone, which is parallel to the long axis of the petrous part of the temporal bone, it is called a longitudinal fracture. Fracture is when the fracture line passes perpendicular to the long axis of the petrous part of the. Horizontal fracture is when the fracture line passes perpendicular to the long axis of the petrous part of the temporal bone. The damage to the facial nerve is much more common in horizontal fractures. So, only two questions to be asked in traumatic facial nerve paralysis. Was it immediate facial paralysis or delayed? Second question, was it complete paralysis or was it incomplete? Exploration and repair of the facial nerve injury surgically is done only if the and complete. In any of the other possibilities, we have to wait and give steroids and other medical management for allowing the facial nerve to regenerate on its own. Okay, one syndrome that we study is a Melkersson syndrome, where there's a facial paralysis, swelling of the lips and fissured tongue. The management is same as Bell's paralysis, but it has more recurrence rates. Ramsay syndrome is generally seen in some of the patients where the involvement by herpes zoster virus, there are vesicles in the external auditory canal, facial paralysis. It's also managed the same as Bell's, but here also the recurrence rates are more. And there is a lot of pain when the rashes develop in the external ear. This is one of the tricky situations when there is a facial nerve weakness that develops after middle ear surgery, especially the mastoid surgeries. That could be because of local infiltration, a thermal injury, or mechanical injury. We have to explore and repair if it persists after 6 hours and if the surgeon is not sure whether he has identified the nerve and preserved it. Otherwise, we can wait. Parotid surgery and intratemporal tumors. Okay, there are very few intratemporal tumors, especially meningioma and acoustic neuromas, which develop near these. Okay, in parotid surgery, what happens? There are branches of the facial nerve. Fine. So in this picture, this is the trunk of the facial nerve, which is identified during surgery. The nerve has just left the stylomastoid foramen, and here it is about to go inside the parotid gland. So this is the trunk of the nerve. So here in this picture, when the tumor of the parotid has been removed, and the nerve now divides into its branches. So this is one branch, There is another branch, there is another branch. So what we do during parotid surgery is that we lift the tumor away from the facial nerve and we remove it, dissect the entire area, we remove. What happens during surgery is that there is a lot of stretching that develops during surgery. So because of the stretching, the nerve may show weakness after the surgery. So most of the time, what happens after, if there is a mild weakness, it recovers on its own. Sometimes a branch may be cut, may be accidentally transected during this surgery. In that case, the facial nerve recovery may not be as good as possible, and we may have to explore and repair the nerve later. Okay. Now, once the facial nerve weakness is developed, facial nerve paralysis is developed, what could be the complications? If there's incomplete recovery, exposure keratitis, because the eye is not getting closed properly. So the cornea remains open and it becomes dry, and there could be exposure keratitis. Synkinesis is a problem when you want to contract one muscle and simultaneously other muscles also contract. That means you want to smile and your eye also closes down along with it. Spasms are common after facial nerve recovery. That means when you want to eat something, there would be tears rolling down from your cheeks. Praise syndrome, that means there will be sweating on the cheek on the time of eating. And okay, we discuss some psychological aspects. Of course, nobody wants their face to be paralyzed. Everybody wants to express the emotions very well. The nerve is very much concerned and connected with expression of all the emotions. So we need to counsel the patient also that okay, it may take time to recover. During that time, you may not be able to have a good cosmetic appearance of the face, especially while trying to smile, trying to blink. So many of these aspects need to be discussed with the patient. Sometimes they may require psychological therapy, psychotherapy. Know the flow chart, when to do the surgery, when not to do the surgery. Cases. Only decompression can cure many of the cases. If there is a complete transaction and the gap between the two ends of the nerve is less than 4 mm, then we can do an end-to-end anastomosis. That means you have to take a stitch from one end to the other end, and then you can anastomose it. Generally, it heals very well. Cable graft is required. Generally, it is taken from greater auricular nerve in the neck. Here is the greater auricular nerve area. When the distance between the two cut ends is more than 4 millimeter. In extreme cases, there is a lot of tissue loss of the nerve. We may have to do a hypoglossal facial anastomosis. And there are many plastic procedures actually to give a good motor appearance to the face. Fine, there is a lot of reading given onto the internet. You can go through that. You can refer those areas. So in summary, I would like to say that there is a nucleus of the facial nerve, which is in the pons, and there is supranuclear part where the nucleus is connected to the opposite side of cerebral cortex. For the lower part of the face, or the same upper part, for the upper part of the face, the same side of cerebral cortex also supplies some supply to the nucleus, and it has also connections with thalamus. Then there's the infranuclear part, then leaves the pons, goes into the cerebello-pontine angle, and then the facial nerve joins the eighth nerve. They both travel together through the internal acoustic canal. After coming out of internal acoustic canal, the nerve becomes labyrinthine portion, then there is tympanic portion, and there is mastoid portion. The three branches is known as greater petrosal nerve, given at the junction of labyrinthine and tympanic portions, which supplies secretomotor fibers to lacrimal glands. Second branch is given at the junction of tympanic portion and mastoid portion, which is called the nerve stapedius. Third branch is given in the form of chorda tympani from the vertical part, from the mastoid part of the facial nerve. The nerve comes out to the stylomastoid foramen, enters the parotid gland, gives terminal branches. Bell's paralysis develops when there is, which is still known as idiopathic paralysis. Some people consider it to be because of herpes simplex. It is idiopathic, sudden, and complete paralysis. The management is that most of the cases it recovers with the steroids. If after many weeks, and if because of many electrical tests, there is a protocol in which we may have to do a middle cranial fossa decompression of the nerve. There are very few situations when we have to do that. Traumatic paralysis of the facial nerve develops when there is a fracture of the temporal bone. And in that, we have to see two things. If it is complete and immediate, we may have to repair it surgically. Otherwise, it recovers on its own. And if while repairing the facial nerve, if there is a complete transaction of the nerve and the two ends of the nerve are very much uh, near, less than 4 millimeter distance, we may do an end-to-end anastomosis. If the distance is more, we may have to do a cable grafting. And in very tricky situations, very special situations, we may have to do a hypoglossal facial anastomosis, or we may have to do some plastic procedures. Thank you very much for this very good session. Do contact me if you have queries. My email ID is here. Okay. Goodbye and do take care of yourselves.